Hi, my name is Matt Mead. I'm a paramedic currently working out in Victoria, and today I'll be discussing and demonstrating a type of obstetric emergency known as a breech presentation. In this video, I'll cover many of the key aspects of a breech presentation, including pathophysiology, risk factors, key management principles, complications and the maneuvers required to assist those complications, and finally, I'll cover neonatal resuscitation.
So firstly, what is a breech presentation? Well, a breech presentation is when the fetus presents buttocks or feet first rather than your head first cephalic presentation. It has significant implications in terms of delivery, especially if it occurs at term. Breech deliveries carry a higher perinatal mortality and morbidity, largely due to birth asphyxia and trauma, prematurity, and an increased incidence of congenital malformations. As you can see here, there are three main types of breech presentation. The first one, a frank or extended breech, is where both legs are flexed at the hip and extended at the knee. A complete or flexed breech, where both legs are flexed at the hips and knees. And a footling breech, which is where one or both legs are extended at the hip so that the foot is the presenting part. The most common type of breech presentation is a frank breech, and that's the type of presentation we'll cover in this video today. So why does a breech presentation occur? They usually occur because of conditions that change the vertical polarity or the uterine cavity or affect the ease or ability of the fetus to turn into the vertex presentation during the third trimester. We will talk more about some of the risk factors associated with this in the next part. So what makes a breech presentation such an obstetric emergency? Well, the main issue in breech deliveries is that the larger head and shoulders are born after the buttocks. This may cause the head to be stuck in the pelvis. Other issues are that the fetus may inhale amniotic fluid, as the sac may rupture with the delivery of the buttocks, or that the cord may become compressed, comprising oxygen to the fetus. As well as this, especially with a complete or footling breech, there is a higher risk of a cord prolapse. This is when the cord slips in between the fetus and the cervix if the amniotic sac breaks in a gush. This is a rare occurrence, but it's a medical emergency. There is also the possibility of an intracranial hemorrhage as a result of the rapid compression of the head during delivery. This is why it is so important during the Morisot-Smellie-Veet maneuver to be incredibly gentle with the head and support it properly. Next, I'll move on to discussing some of the risk factors and causes of a breech presentation. There are a number of risk factors that can cause a breech presentation. These include polyhydramnios, where there is too much amniotic fluid around the fetus during pregnancy, uterine abnormalities, such as bicornuate, a heart-shaped uterus, and septate, which is a normal uterus with a wall of tissue creating two cavities, lesions such as uterine fibroids, placental abnormalities such as placenta previa, multiparity, and fetal anomalies. There are also a number of key management principles to consider in the pre-hospital environment. These include immediate transportation to an obstetric hospital if the birth is not imminent. However, if the birth is imminent, we should be setting up neonatal resuscitation equipment and requesting community midwife attendance immediately. Managing the mother's pain with drugs like penthrane is key, and maintaining a hands-off approach as much as possible through the birth is important. We also need to remember the tummy to mummy principle, which is where the fetal back should always be anterior to the mother. Now that we have a better understanding of what a breech presentation is, its causes, key risk factors, and key management principles, I will now demonstrate how to fully deliver a frank breech birth. So prior to this point, I have performed an obstetric primary survey and identified that birth is imminent. Neonatal resuscitation equipment is set up, community midwife has been called, and the patient has been given 3 ml of penthrane via an inhaler. The area has also been prepared for delivery with warm towels, and the mother has been positioned in a semi-recumbent position with legs in the lithotomy position. From here, I encourage the mother to push with contractions and maintain a hands-off approach while constantly assessing for any potential complications. The fetal legs and arms spontaneously deliver. I then wrap the baby in a warm towel, complete the Morisot-Smellie-Veet maneuver, and lay the baby on the mother's abdomen for skin-to-skin contact. I then reassess the baby's tone, breathing, and heart rate. I will now discuss the two main complications and manoeuvres associated with a breech presentation. Firstly, the love sets manoeuvre, which is used when the arms don't spontaneously deliver, and secondly, the Morrisseau-Smellie-Veet manoeuvre, which is used to safely deliver the head when it does not spontaneously deliver. If the arms do not spontaneously deliver, the love sets manoeuvre may be required. Step 1 of the love sets manoeuvre is to gently place your fingers on the fetal pelvis and thumbs on the sacroiliac region. This is important to avoid injuring internal organs. Step 2 of the love sets manoeuvre is to gently rotate the fetus 180 degrees, applying downward traction to allow the arm that was posterior to become anterior, which then allows it to be delivered under the pubic arch. Repeat this step for the second arm. Step 3 is to assist delivery of the arms by running 1 or 2 fingers over the shoulder and down into the brachial plexus. You then sweep the arm in front of the fetal body. Finally, once both arms have been safely delivered, gently rotate the fetus to the original position of back uppermost. I will now demonstrate the love sets manoeuvre. As you can see, I am maintaining a hands-off approach and allowing the baby the opportunity to deliver spontaneously. The baby's right arm almost spontaneously delivers, so I assist with a 2-fingered sweeping motion to fully deliver the arm. I then place my fingers on the fetal pelvis and thumbs on the sacroiliac region and rotate the baby 180 degrees to move the baby's left arm into an anterior position. I then repeat the 2-finger sweeping motion to deliver the left arm and rotate the baby back to a neutral position of back uppermost. After the love sets manoeuvre, if the head does not spontaneously deliver, the Morrisseau-Smellie-Veet manoeuvre may be required. Step 1 of the MSV is to gently place 2 fingers of one hand on the malar bones of the fetus to support the head. Step 2 is to gently hook the index and ring fingers of your other hand over the fetal shoulders and place your middle finger on the fetal occiput. The third and final step is to gently flex the fetal head towards the chest to bring the fetal head down until the hairline is visible. Gently pull to deliver the head and deliver the baby to the mother's abdomen for skin-to-skin contact. I will now demonstrate the Morrisseau-Smellie-Veet manoeuvre. As you can see, I gently place 2 fingers of one hand on the malar bones to support the head. On my other hand, I gently hook my index and ring fingers over the baby's shoulders and place my middle finger supporting the baby's occiput. I then gently flex the head down to deliver and pull the baby upwards and outwards to fully deliver the baby. While delivering the head, it's important to have your partner push down just above the pubic bone to help keep the baby's head flexed to assist delivery. I will now demonstrate the full delivery of a breech birth, highlighting both the love sets and the Morrisseau-Smellie-Veet manoeuvre. As you can see, I am maintaining a hands-off approach in the hope that the legs will spontaneously deliver. If the legs don't spontaneously deliver, I will assist to deliver them by placing 1 finger under the knee and sweeping the leg forward. I will then repeat the process for the other leg. From here, I return to a hands-off approach and continue to monitor the fetus and the mother for any potential complications. If the arms don't spontaneously deliver, we will need to use the love sets manoeuvre, as you can see here. I'm being very careful to place my fingers on the pelvis and thumbs on the sacroiliac region to not injure the baby. I'm gently rotating the baby 180 degrees to place the left arm in an anterior position and using 2 fingers to sweep the arm forward. I then rotate the baby back into a neutral position and begin the MSV by placing 2 fingers on the baby's malar bones and using my other hand to hook over the shoulders and middle finger to support the occiput. I then flex the head downwards and pull the baby gently upwards to fully deliver. From here, I then place the baby on the mother for skin-to-skin contact and cover it in a towel to keep warm. Once the baby has been fully delivered, complete an initial assessment of the baby's tone, breathing, and heart rate. If the baby doesn't begin breathing, crying, or has a poor tone, we need to begin neonatal resuscitation. The first step is to prevent heat loss by wrapping in a blanket, stimulate the baby by rubbing with the blanket, and ensuring the airway is open and clear. If the heart rate remains below 100 or they are apneic, commence positive pressure ventilation if available. If their heart rate remains below 100, you should check the airway is open and clear, ensure there are no leaks in your equipment, and increase pressure and oxygen. If their heart rate drops below 60 beats per minute, commence CPR at a rate of 3 compressions to 1 breath at 100% oxygen. Consider the use of an ETT or LMA. If the baby's condition doesn't improve from there, gain IV access and administer IV adrenaline at 10 to 30 micrograms per kilogram at every 2 to 3 minutes.
Thanks for watching, and I hope this video has given you a bit more of an insight into breech presentation and how to manage it effectively in the pre-hospital environment.